have it uphealed, so I came today. I said they couldn't change until next week. So at least you guys did not have enough heels with somebody else in the class. Yeah, it would have been a little bit more stressful. Don't worry, guys. There are recorded lectures on an GI. You'll be fine. You'll be fine. If it would they were taking neuro away from me, then I'd be like, okay, something's wrong. But we're okay. All right, guys. So HEENT. When we're evaluating the HEENT, we're doing head, eyes, ears, nose, and throat. Okay. And headache is one of the most popular complaints that patients have when they go to the ER, the doctor, the urgent care, wherever. Headache is one of the number one complaints. And when someone comes in with a complaint of a headache, it can be as benign as a tension headache, or it can be as detrimental as a subarachnoid hemorrhage. You have to make the proper assessment to see which headache it is. And based on the symptomology, your history is very important when you're doing a headache assessment. Okay? There are different types of headache. There are primary and secondary headaches. Your primary headaches are headaches that come from the head due to non-benign issues. There are no secondary kind of issues that's causing this headache. Okay? And your primary type headaches are migraines. Migraines, remember, are unilateral. Okay? Unilateral pulsating type headaches. So you want to remember that. That's a distinction from migraine. Unilateral pulsating headaches. Most of the time they're associated with nausea and vomiting. Okay? But it's a unilateral, and a lot of times it's one side of the face can involve some aura. Sometimes they have auras associated with them. Sometimes they have nausea and vomiting associated with them. Okay? These are your migraines. A lot of times it comes around one specific time for women around their menstrual cycle, so it can be hormonal. Okay? You have tension type headache is I am stressed. Okay? They told me my professor's gonna change. Yeah. And I'm going home with a headache in the back of my head, and it feels like a pulling tight band around my head. That's your tension type headache. Okay? Band-like stress-induced type headache. Okay? And these are your benign primary type headaches. Okay? Your tension headache, your migraine headaches, these are primary. The next one is your cluster. Your cluster headaches have a specific pattern. It's usually occurring at the same time of day. It's usually an elderly male over the age of 60. Okay? It's centered around one eye. There's tearing from that eye, and there's drainage from the nasal passageway associated with this pain. It is excruciating pain over that one particular eye that usually occurs. Okay? That's your cluster type headache. Okay. And then you have your chronic headaches. Your chronic headaches sometimes are due to medications. So let's say I have migraine headaches and I take an Ergot, or I take a Triptan. Okay? These headaches, these medications can cause a headache that can actually be a chronic type headache that can be associated with the medications that they're taking. Okay? People who have like chronic back pain, they can have headaches from taking narcotics. Chronic narcotic use, okay, can give you headaches. So these are your chronic types of headaches. And then your secondary headaches. If I have a brain tumor and I have a headache that's actually pushing on the brain, tugging on the meninges, this is structural lesion, this is that secondary type headache. Okay? I can have a systemic headache, or a headache that comes from, let's say I have like a pseudotumor cerebri. Okay? I can have a headache from that. We'll talk about what that is in a little while. or an infectious type headache. I can have an abscess, or I can have a meningitis. Okay, these will give me my secondary type headaches. Okay, so it depends on what's going on can give you these secondary type headaches. The secondary type headache is not coming primarily from the brain, it's coming from something else. Okay? Headache warning signs are very important for when you're assessing, when you're doing your health history. These right here, you need to make sure that you assess for. So warning sign, anyone who has a new onset headache and they're over the age of 50, before you say something like, oh, it's a migraine or a tension type headache, you're supposed to be saying, okay, could this be a stroke? Is this a hemorrhagic stroke? Or is this subarachnoid hemorrhage? Or is this a brain tumor? Okay? Anyone over 50, they've never had headaches before, and now they come in with a new headache, that person needs a CT scan. Okay? You must ask these questions. Someone over 50 comes in and you're taking their health history. Is this the first time you've had this type of headache? Or is this your first headache? They're like, you know what? I may have had a headache way long ago, but I don't even remember. I don't really have headaches. That's a warning sign. That's a grave warning sign. Okay? That's a red flag. So you want to tag that as red flag. Aggravated or relieved by position change. If I lay flat in the bed, okay, my headache is worse. When I get up in a standing position and I walk around, my headache is better. When I lay flat, increased intracranial pressure. So if I have a space-occupying lesion in the brain, I can have increased intracranial pressure. And those are the patients that usually wake up in the morning with the worst headache. And the headache is better as the day go by. So patients with increased intracranial pressure, they tell you that it's aggravated or relieved by position. If I'm laying flat, my headache is worse because I have increased intracranial pressure. If I'm laying, if I'm in an erect position, my headache is better because increased intracranial pressure is relieved. Okay? When you're in an upright position, you don't have that much pressure on your brain or the meninges, and you have more space. The CSF is flowing. You can actually, the pressure can go down on the brainstem, can go down on the spinal cord. You don't have just stuff laying there. Okay, so you have this relief in position change. That's a worrisome headache. That's a headache that you want to think about increasing intracranial pressure. Okay. Precipitated by Valsalva, increased intracranial pressure. Okay? Anybody who has, okay, I bear down and my headache gets worse, think about increased intracranial pressure. Space occupying lesion, they can have a hemorrhage, they can have a abscess, something in the head. So you want to think about space occupying lesions. Associated with fever, night sweats, or weight loss. Think the only things that are associated with fever, night sweats, and weight loss are what? TB, cancer, HIV. These are your three things. Someone comes in, they have fever, night sweats, and weight loss. Endocarditis will give you that too, but then you still worry about if they have a headache too, because it can actually throw, clots that come off or vegetation up into the brain and cause, abscesses, okay? So fever, night sweats, weight loss, you want to think of an infectious process, HIV, TB, cancer, and in those cases, you know that the patient can possibly have a space-occupying lesion or something else, okay? Presence of cancer, if the person has cancer, you know, you're thinking metastasis. Patients, presence of HIV infection, they can have increased intracranial pressure. Pregnancy, they can actually have increased intracranial pressure from things like hypertension. They can have a stroke, hypertensive bleed, depending on what's going on with that person. Okay. Recent head trauma, a skull fracture. Okay. Associated papilledema could be meningitis. It can also be pseudotumor cerebri. It could also be a subarachnoid hemorrhage. So if it's associated with stiff neck or focal neurologic deficits, you're thinking subarachnoid hemorrhage, meningitis, all these things that you want to be thinking. So when you're doing your assessment and you're doing your health history, you're going to ask all these questions. Okay? You got to gather this information, because this information is going to be crucial in you making your diagnosis. So this is all part of your assessment. Okay? Any questions on that? Okay. Is the headache bilateral or unilateral? Okay? If it's a band-like headache that goes across, bilateral, more tension. Unilateral, migraine headaches are almost always unilateral, and cluster too. Okay? Is there a prodrome? Is there an aura? Do I have a vomit? Do I smell something prior to the headache coming on? Okay? Also remember, if the patient's over 40 and they have, or the patient's over 50, I shouldn't say 40, over 50, and they're taking oral contraceptives and they have, they have migraine headaches, they're at high risk for strokes. So you have to make sure that you pay attention to those patients. If they're over 50 and they tell you that they're on oral contraceptives, they come in with headache, you want to think about strokes because they're high risk. Okay? Overuse analgesics, if they're using analgesics for pain, headache control, for greater than 15 days they have a headache, and then you stop, and the headache goes away, you know that this is overuse headache. Okay? Ergotamines, triptan use, all these can do it. Family history. Family history is very important because I have seen patients, my mom had an aneurysm, my brother had an aneurysm, my grandmother had an aneurysm. Guess what? You probably have one too. Thunderclap headache, worst headache of your life? Aneurysm rupture. It's very real. Okay? So family history is very important to ask. Okay? All right, so head assessment. When you're looking at the head, you want to actually look at the hair quality. Is it sparse? Is it evenly distributed? Is it fine? Because if they have really fine sparse hair, what are we thinking? Thyroid, hyperthyroid, okay? If they have thick, coarse hair, hypo, okay? Can definitely be hyper or hypothyroidism. You want to think about that, huh?
Or Accutane use.
Oh yeah, they could be using some kind of drug too. Okay? You want to look at the scalp, mites, lumps, bumps. If the person had a head trauma, you have to look at the scalp to make sure that there's no subgaleal hematomas. Okay? Lesions in the head can tell you a lot about their hygiene. Okay? Mites, okay, can tell you what their house looks like, or where they live. If they live on the streets, you can tell. Scalp deformities, especially in kids, you want to check for the fontanelles. Are the fontanelles closed, or are they open? Okay? Are they widened? Patients who come in with hydrocephalus, especially kids who come in with hydrocephalus, you'll see the fontanelles widened. Okay? So you want to check for that. Facial expression. Do they have mass faces? Because then we'll think of Parkinson's disease. Okay? What's their affect look like? Do they have facial, is their face symmetrical? Or do they have a droop on one side? Meaning they had a stroke. Okay? Skin. You want to look at the face. Do they have any lesions on the face? Do they have any fungus or anything like that? Those things are very important. Is it even colored? Do they have discolorations all over the face? Or discolorations all over the head? What does that look like? Okay? And is the skin thin or is it thick and coarse? Okay, because that will tell you a lot of times hormonal issues. So you want to palpate the head, you want to look for contour, okay? You want to look for tenderness. If I palpate Kat's head and I go right around here and I palpate and she screams, I'm thinking about temporal arteritis, okay? Because this is an inflammation of the temporal artery that can actually occur, and it's usually older people, but they come in with this one-sided headache. They have these tiredness symptoms. These usually like weird symptoms that they tell you. Have been fatigued, have been really tired, and then you go palpate their head, and they scream once you touch the temporal area, temporal arteritis. Okay, very common in elderly. Okay. Tenderness to skull due to traction from brain abscess, very possible. If you see this, they need a stat neurosurgical consult. Don't worry about that. Auscultate the orbit and skull for cranial groove. You want to check. It's a lot of times hydrocephalus. You can get that. So you want to inspect, palpate, auscultate in your patients when you're examining the head. Face. Facial expression. Are they flat? Do they smile? Are they smiling inappropriately? It's like you have cancer, you're about to die. It's inappropriate, you know? So that's, you want to take note of that, because that could be a frontal lobe lesion, okay? Look at the color, are they flushed, okay? Or do they have different discolorations? Symmetry of eyebrows, okay? When we do neuro, we're going to talk about this again, but cranial nerve 7 is your facial nerve, okay? And you can't do HEENT without going through the cranial nerve. So you're going to get cranial nerves now, you're going to get it again. So it's easy, you'll remember it, okay? Cranial nerve 7 is your facial cranial nerve. Facial, you can manifest abnormalities 2 ways. You have central versus peripheral, okay? If the patient has a cranial nerve palsy, they'll have drooping of one side of the face, okay? If they have drooping of one side of the face, you have to determine, is this central or peripheral? Peripheral is due to things like Bell's palsy, okay? Central is due to things like strokes or brain lesions coming from the brain. If it's central, the lower part of the face is what's going to be affected. If it is peripheral, it's going to be the entire side of the face, okay? So, when you're looking at a patient, when you have a patient with Bell's palsy, what usually do you see? One side droop, and what else? The eyes toast? No. Usually they cannot close their eye. Usually you cannot close your eye. Usually if you have a patient with a complete 7 nerve palsy due to a peripheral issue, you have to actually keep their eye closed. And you have to keep putting drops in their eyes. Remember?
Yes.
So cranial nerve 7 has multiple functions. Facial asymmetry, it actually closes the eye. Cranial nerve number 3 opens the eye. That's where we were getting it mixed up just now. Cranial nerve number 7 closes the eye. So if they can't close the eye, it's usually a cranial nerve 7. Okay? So if you're seeing the whole face droop coming from the forehead all the way down with the eye open, that's a peripheral cranial nerve 7 palsy. That is not central. If it's just the lower part of the face that's drooping, that's a central cranial nerve 7 palsy. Okay? So it makes a difference. Okay? If you see the whole face, you're not thinking, okay, well, this is a stroke. And it could be. If it's in the brainstem, it can definitely be. But it's much less likely to be a stroke. So it'll be central, lower part of the face, unless it's in the brainstem. And you'll never get tested on that because even internists don't know that. Even ER physicians don't know that. They don't. So, you never get tested on that. But it is, if it's in the brainstem, you can have a whole cranial nerve palsy. But that's a different lecture. Lower part of the face, central, entire face, peripheral. Okay? All right, guys? Mm-hmm. Make sense? So how do you assess for it? Smile, frown, puff your cheeks up. Okay? That's cranial nerve 7. Okay? Smile, frown, puff your cheeks. Close your eyes really tight. Don't let me open them. Okay? That's cranial nerve 7. Because if you can close your eye, cranial nerve number 7 is working. Okay? If you can't close your eye, then it's cranial nerve number 7 is not working. Okay? Cranial nerve number 5 is trigeminal. Your trigeminal has 3 strands, V1, V2, V3. Always put your hand on your face, V1, V2, V3. That's your strands of cranial nerve 5. Okay? And usually, you can have trigeminal neuralgia, all these things that can give you these pain in that facial cranial nerve 5, but usually you're testing to see if there's sensory in cranial nerve 5. Now remember, there's a motor component to cranial nerve 5, and that's checking your trigeminal, your TMJ, to make sure you have good strength. Okay? So if I tell you close your mouth and don't let me open it, that's not 7, that's 5. Yeah, a lot of people mix that up. Close your mouth, don't let me open it, they think they're testing 7, that's 5. Okay, because you're checking the trigeminal, you're checking the TMJ. Okay, open your mouth and close, open your mouth and close, and you palpate, that's cranial nerve 5 also. Okay? So remember, cranial nerve 5 has 2 components. It has a sensory. You have to test through all 3 strands of cranial nerve 5, sensory and motor. Okay? And the motor part is only open your mouth, open and close, and you palpate. Okay? We good?
Yes.
Okay, so abnormal facial appearance. What does Parkinson's face look like?
Flat and
Mass faces. It's like, it's not even like a flat affect. It's like they can't even move the face to smile. Okay? Cushions, usually it's puffy cheeks. Okay? And a lot of times you'll see like the, they'll have like the, really chubby cheeks. Okay? Poofy face, and then their eyes are poofy. Okay? Hyperthyroidism, bug eye. Those are the people, have you ever been in the mall, you see them walking and you go, oh, you need an endocrinologist. It's like you need some Tapazole. Okay? You see them all the time. Okay? Myxedema, they have really thick skin on their face. Okay? Bell's palsy, we just talked about it. Half the face is gone. CVA, a stroke, lower part of the face. Scleroderma, they have this face that's like a mass and it doesn't move anywhere. It's like tight and they look like they had Botox. Okay, that's your scleroderma. They look like they had Botox went really, really, really wrong. That's what you have to look at. Because their face is like that and it doesn't move. Okay? Fetal alcohol syndrome. I have a picture of it. Look at it right here. The slanted eyes, the slanted lips, the low setting ears. Usually your fetal alcohol babies look like that. Okay? Macroglossia, big beefy tongue. Okay? Down syndrome, they have the sunset eyes. Okay? Usually what they look like. All right. Any questions on the face or the head, guys?
I do.
Yes.
I worked with a PA at her eyes when you go to, doesn't go away with vision.
Sometimes no. A lot of times it doesn't. And sometimes you even have to do the thyroidectomy, sometimes it doesn't. They have the really bad proptosis and it stays. And some people are just born that way.
They were really big out.
Is Bell's palsy permanent?
No, it doesn't, it's not permanent. You can actually treat Bell's palsy
I had
with
it, it went away.
steroids. Huh?
It went away. I was
Yeah.
a senior, it took me 6 months.
Yeah. It sometimes takes longer than others, but it goes away. It's a long treatment of steroids
vitamin B12
Patience, B12 they give you, patience, a lot of patience. And there are people who have it recurrent because theirs is usually induced by stress. So every time they get a stressful episode, it comes back. Okay.
Thank God we don't have those Palsy
What?
today. After the news,
Episode has busted today.
all of our faces would be crooked.
Stop it. Also dramatic. Stop it. They're gonna say I'm influencing my students. All right, guys. So, visual loss, very important. Is this a gradual thing or a sudden thing? Any sudden visual loss is a medical emergency. You need to get them to Baskin Palmer ASAP. Okay? If they tell you it happened over days, not so much. Even that is an emergency. But if they tell you from one minute to the next they couldn't see a thing, that is a medical emergency and must be treated immediately. Okay? Where is it coming from? Okay? Is it coming from the eye or is it coming from the brain? Central versus peripheral. Hemianopsia. That means one part of your visual field is gone. Quadrantic defects. That means quarter of your visual field is gone. Okay? Hyperopia or presbyopia, it usually means that you can see far, but you can't see near. Presbyopia is aged eyes. That's where I'm going. Okay. I call my friend and we call it vaginal view because we put everything down here to see it. That's what we call it. We have you're looking at a paper and you're trying to read it, you go. So we call it the vaginal view. Okay? Myopia, I can see everything in front of me, but I can't see far. Okay? Blurred vision, if they complain of blurred vision, is it sudden or gradual again? Is it unilateral or bilateral? It's very important for us to assess these components in our history taking so that we can kind of get to what disease process we're looking for. Okay? So this is what the normal eye looks like. Very nice eye. Okay. So we have the outer eye and the inner eye. Okay? When you're looking at the fundus through your ophthalmoscope, you're looking at the inner eye. Remember, your ophthalmoscope looks at the fundus. The fundus includes the retina, the optic disc, the macula, and the fovea. The macula is like the dark part that's in the eye. It's a darker part, and the fovea is right in the middle. Okay. The macula. When we have macular degeneration, when the patient has macular degeneration, what's going on with their vision? What usually happens?
Like
The macula is for region for keenest vision. Usually what happens is they can see around, but they can't see in the middle. So people who have macular degeneration, they cannot read. And they do this, yes. It's like a T-Rex. Right? They cannot read because they cannot central their vision. They can't center their vision to read this paper. So they're like turning their head from side to side to try to see. Because their peripheral vision is intact, but their central vision is gone.
You can get like a transplant? Macular transplant?
I don't know. I don't think so. I think you need an eye transplant. And they do eye transplants, yeah.
You donate your eyes.
That's why the organ donation people take people's eyes.
Let's see video of my work.
Yeah, corneal transplants. You can do eye transplant. So yeah. Did you watch that movie with Will Smith when he donated all his organs?
Yeah.
And then the girl went to meet the guy and she was looking into his eyes so she could see him.
Is that 7 pounds?
Oh yeah, that's that's a deep movie. Deep movie. Yeah. If you have never seen it, you should see it.
What's the name?
7, what do you call it?
7 pounds.
7 pounds. That movie was like, I think that's one of his best movies, but it didn't get the ratings or the hype that it should have. Because I think people are just not deep. And you have to be deep to understand it. Yeah. He went crazy. His
Well,
wife.
the same with, well, the same with concussion.
Yeah, concussion they hit it either. All right. So the outer layer is the sclera. The middle layer is the cochlear ciliary body. The ciliary muscle is what contracts the pupil. The iris controls the diameter of the pupil also. The pupil allows the light to, it actually accepts the light reflex and takes it to the retina, and the retina is what takes it to the brain to be interpreted. The lens to refract and focus the retina, and then you have the anterior chamber, which is filled with fluid. You have the optic disc, where actually is the point of entry for the nerves. So if you have an optic neuritis, it's usually a nerve that's inflamed. And if you have a papilledema, where the optic disc is being pressed on, you can get optic neuritis, or you can get optic disc damage from that. And remember, these nerves, there are multiple nerves that comes out of the optic, going to the nerve of the eye to input information to the retina. And then you have also major vessels come through the optic disc to supply the retina. Okay? The retina is actually considered neural tissue. It is part of the eye, but it's actually considered a part of the brain because it's actually an interpretive part of the eye. Okay? Macula, again, keenest vision, and then fovea. Your fovea is right in the middle of the macula, and that part of the eye is the sharpest part of the central vision. So if your fovea is gone, your keen sense of like observing and your central vision is gone. Points to remember: the fundus of the eye contains all this: your macula, your fovea, the posterior part of the eye, the retina. All of that is housed in your fundus. So when you're doing your health assessment exam and you say, I see the fundus, it's a yellowish orange in color. I see the optic disc, it has some sharp margins. You don't have to say the macula and the fovea, because then we'll know you're really lying. You ain't seeing none of that. So you just said you see an optic disc, there's sharp margins. And then you can say I see vessels, okay? Or I see arteries and veins. But you want to keep it nice and, you see the fundus, that's that big orangish color. You don't see blood there. That's one thing you usually look for, if there's blood in the back of the eye or anything like that. Okay. This is the eye anatomy. You do not have to memorize this. You do not have to know where anything is. It's a vitreous body and has vitreous humor in it. At the ciliary body. This is the lens, pupils in front there. Gets the light reflex, takes it back to the retina. Okay. This is your optic disc here where the nerves come out, and then the blood supply also comes out. Okay. The sclera is the outermost portion, cornea. The lens, the iris, which actually helps to contract and constrict the pupil. The conjunctiva. And that's pretty much it. This is your macula. This dark area here, and the fovea is right in the middle of the macula. Okay. And then your optic disc, your nerve, and your vascular areas that comes into that. Okay. So, the ophthalmoscope. That's what you're looking for when you're looking at the fundus of the eye. You're looking at the posterior most aspect of the eye. Okay. But before you can get there, you have to actually look at the external aspects of the eye.
What are you learning?
Huh?
What are you teaching?
I don't know. They don't learn a thing in this class.
I don't believe it. I don't believe it. Acute?
No, this is actually health assessment.
Oh, wow. Very
Yes, this is health assessment. This is your dean, guys. If you've never met him, this is Dr.
Are we
McFadden.
doing orientation?
Yeah.
Sort of. I was
They
probably.
said 25,000 years ago.
I was
And
just
this
gonna
is
say,
only their
I had
second
darker
semester.
hair, I was thinner, I was married to my first spouse.
We love
This is
Dr.
that first part.
Martin. Dr. Martin's great.
Yeah, we
Yes.
are.
She's pretty good. She's tough.
No, she's not.
Very
to work today?
No, I keep them busy and keep them occupied. They're nice. None of you look exhausted.
Don't keep them here too late, please.
I try. I send them home.
We cannot get enough of her, that's.
Have a good evening.
All right, take care. Okay.
That was so random.
So the posterior part of the eye is visualized. Very random. It's okay.
I was this close of telling him, have a seat. Stay here with us.
Observe it, right?
That's why I said 25,000 years ago.
Okay. So the external eye, visual fields, pupillary retraction. I don't even know what I'm saying anymore. So, outer eye. We're gonna open the eye. We're gonna look at the conjunctiva and the sclera. Okay. If you have a question and it talks about an injected eye, it just means it's red and irritated. Okay? If you hear injected, if you read anywhere in the sentence that the eye is injected, it's just red and irritated. Okay?
Why can't they just say red?
I know, it's injected. We're in the medical field, we like to we like to complicate things. That's how we do it. Okay? So you're gonna actually, when you're doing your assessment, you're gonna actually hold the bottom of the eye and you're gonna pull down on the lids like this and look into the eye. Okay? You're gonna look at the sclera, you're gonna look at the conjunctiva. Okay? And you're gonna talk about the sclera is nice and white, conjunctiva is nice and pink. Okay? It's not red, it's not injected, if you wanna say that. I'll give you an extra point if you get that.
Oh, okay.
Okay? I'll give you an extra point if you just tell me that. Okay. The Snellen chart. The Snellen chart tests visual acuity. Which cranial nerve is visual acuity? Cranial nerve 2. Okay? Remember, cranial nerve 2 is sensory. It tests visual acuity. Okay? And it works very closely with cranial nerve 3. Okay? Cranial nerve 2 and 3 kind of go together in a lot of things. Okay? The Snellen chart. When you're testing with the Snellen chart, you're checking cranial nerve 2. Okay? And it is the first part of your eye exam. It is the first part of your eye exam because this is the least invasive. You're not even touching the patient. Okay? It's the least invasive. You're not touching the patient. The patient is standing and you're reading the numbers. Okay? So 20, let's say my vision is 20/20. It means that I can see from 20 feet what the average person can see from 20 feet. Okay? If my vision is 20/30, that means what most people can see at 20 feet, I see 30 feet. No.
What's some?
What
It's the other way around.
Yes, the other way around. Well, most people can see at 30
At 30
feet.
feet, you can see at 20.
No.
Yeah, like you have to be closer to the object to see what someone
Someone
else can see, like if they are
So,
farther.
If they're 20/30, that means I have to be closer to see it, what someone else
yeah.
can see further.
So the higher the
If
number,
it's
the worse your
the worst
vision
vision
is.
Say it in a sentence. I got a test question.
I know, right? I like it. If a patient has a report of 20/50 vision, this usually means that, and choice 1 would be what a normal person sees at 50 feet, you have to see at 20 feet.
And that wouldn't be it.
That would be it.
That would be it.
Okay? So the first is how far the patient is from the chart. The second is the distance in which the normal eye can read the letters. Therefore, the higher the second number, the worse the vision.
Who establishes that?
Just a whole bunch of studies that they did a long time ago. Okay. So when you're doing your eye exam, I want you to remember this chart. Because I see people go and they pick up the ophthalmoscope first. That should be the last thing you do. So you want to start external examination. Okay? Then you can do visual acuity, pupillary function, ocular muscle mobility, visual fields for confrontation. You're not going to do intraocular pressure, but then you do ophthalmoscopic exam.
So for the purpose of the,
You're not going to do a visual acuity test.
thank you.
Okay?
You're gonna have a study chart, right?
You're gonna no. You're gonna tell them that we'll give you the paper, and then we'll say the Snellen chart will be there. The Snellen readings.
We didn't want to do
So you want to
that,
follow
okay.
this order for the actual company?
No, because you're not gonna do visual acuity. You're not gonna do that. But yes, the order you're gonna do is external examination, pupillary function. You can do actually pupillary function first, or you can do extraocular and confrontation, and then pupillary and ophthalmoscope. I like it that way because, and then you have the machine in your hand. You're not putting it down.
Right.
Okay? But this is a normal recommended way. Actually, this is a recommended way to do it. Okay? Do not do this first. A lot of people do that. Okay? When you go to this first, you irritate the person's eye. They don't want to follow with any more exam that you have. Okay? So, abnormalities of the eyelids. Periorbital edema, puffy eyes, you can see that with cushions. Exophthalmos, bug eyes, you can see that with hypothyroidism. Endophthalmos, sunken eyes, you see that with nutritional deficiencies. What else do you see it with? Nutritional deficiencies, you see it more. Ptosis, and again, anybody says the P, you're in trouble with me. It is not ptosis. It is ptosis. No, they always do it and it irks the crap out of me. It's like, for me, that's like dragging your finger on a nail board. Dragging your nails on a blackboard, that's my issue. Ptosis is what it is. It's not ptosis. Exotropian and endotropian, I have it here. Endotropian, it folds under. If you look here, you see that the lid is folded under. So a lot of times with the patients, they actually can scratch the cornea. Okay? And exotropia, it actually comes out and it folds out. If you look at this one here, they have their eyelids, like it almost looks like it's drooping down and folds out. Blepharitis and chalazion. Chalazion is like a big, we call it a sty in your eye. Blepharitis is a bacterial infection of the eye.
That's not the star.
This is not the sty,
This
but
is
it's
not
like
the
a,
sty.
it's a,
Cause that
well,
one's
they
not
call it
painful.
people call it a sty in the eye too.
Yeah.
But it's like a hard induration in the eye that
Mhm.
can be associated with, actually they don't even
The-
have anything that it's associated with. Okay? The hordeolium
Yeah,
is
that's
the
the
one that's
sty.
painful,
Yeah, that's the
and they call it
painful one.
sty. But the chalazion, they call it a sty too. They call it a
Okay.
sty in the eye just because. But the
Okay.
hordeolium is the one that's an infection, stay back, it hurts. The chalazion, it does not hurt. Okay? So you want to look at the hordeolium versus the chalazion in your question. If it's painful, it's hordeolium.
Hordeolium.
If it's non-painful, it's chalazion.
Chalazion.
Either way, it looks like a sky in your eye. It's actually infected gland in your eye. And the chalazion is just an inflamed gland in your eye.
Okay.
Cystitis, it's the induration or inflammation of the lacrimal ducts of the eye, okay? Usually there's an obstruction of that lacrimal duct, and it actually ends up with this big induration where there's fluid-filled cavity in that area. Okay? Eye issues are so like disgusting. They are.
Yeah.
They're not fun. Okay? Conjunctivitis, viral, bacterial, allergic. Okay? If it's bacterial, you're gonna see a whole bunch of crust,
It is
yellow
like
crust.
yellow.
Okay? Allergic is just usually redness, irritation, and it's associated with itching most of the times. Viral, you would see redness. You usually don't see the crust on the eye. And chemical, it's just irritating. And then there is usually some history of something being thrown into the eye. Okay. Subconjunctival subconjunctival hemorrhage, is usually just a capillary that bursts in the eye. It's benign, self-limited, it goes away. Iritis is a circumferential redness around the pupil, and it actually can be associated with an inflammatory issue. Glaucoma is actually an obstruction of the canal of Schlemm that actually stops aqueous humor from actually circulating into the eye and can actually increase intraocular pressure. Okay? You have open angle glaucoma, which is not as much of an emergency as an acute closed angle glaucoma. If you have an acute closed angle glaucoma, you know that high increased intraocular pressure, and this patient can actually go blind really, really fast. Okay? Questions on that? We just talked about this slide. Anybody have any questions on this? I don't need to go through it, right? You're good? All right. All right, guys. We talked about these already. Okay, sudden unilateral painless visual loss. These are all the things that can actually cause it. Okay, vitreous hemorrhage. The one thing that you'll see a lot is the retinal detachment, especially diabetics. That's something that you have to pay attention to when a diabetic tells you that it feels like a curtain is coming down over their eye. Okay, that's usually a retinal detachment. Okay? And it happens a lot more in diabetics than anyone else. Okay? Retinal vein occlusion can be sudden, painless. Macular degeneration, depending. Retinal detachment is the one. Vitreous hemorrhage can be. All right. In a following condition, patients often describe a sudden, large flash of light with gradual visual loss in one eye. Vitreous hemorrhage. Okay. No, that's actually retinal detachment. But the one thing that this doesn't talk about is the curtain. See how this is right here? They usually tell you it feels like they have a curtain coming down and it's slowly covering their eye. And that's the retinal detachment. Okay?
So what would they see with the other ones?
What do you mean?
Like the hemorrhage?
The hemorrhage, they may not see anything. It might just be sudden onset blindness. Okay. They can see scrotal floaters and scrotomas, but usually you see that in retinal detachment. The scrotomas, the floaters look like this. They'll see this. And the scrotomas, it's a scintillating scrotomas. This actually is like a moving light. You can't see it because I copied it from online. And they're not going to give me their graphics. But if you look at this, it's usually like, you see how it looks like kind of almost like a wart almost. But what they usually see is like a flash of like light that goes like that. And it's constantly moving. That's what they call a scintillating scrotomas. okay? It's like this flash of light that's constantly moving, and you see it over, when you open your eyes, you see it going like that. You can't see it there, but this is like a wave of light that just constantly moves. And then the vitreous floaters, it just looks like there's a whole lot of things in front of you, when there's nothing. Okay. So, retinal detachment, patient usually provides a history of contributing no trauma, followed by sudden visual disturbance, such as flashing light, photos, scrotomas. The visual defect may advance or progress as the retinal detachment enlarges. Central vision will be retained unless the macula is involved. If the macula is involved, it usually means that they're in really bad shape. These patients need to get to Boston Palma like ASAP. Okay? And this is what it looks like. Vitreous hemorrhage, extravasation of blood into the several potential spaces. This is in that area that we have the vitreous humor, and you have a little vessel that pops, and you have the vitreous hemorrhage. You can have them in any of these areas right here. Sudden bilateral vision loss, iatrogenic. When I say iatrogenic, what do I mean?
Without, like, I don't know what's happening. Under radiology.
No, it usually means that we did it. It's something we did. So if you're in the healthcare field and we say that something is iatrogenic, it's usually we give a drug or something that can actually cause this patient to have a reaction to it. What drugs will give you bilateral visual field loss? Bilateral vision loss. Pharmacology. Anything that closes a pupil, or anything that opens the pupil. Cholinergic.
Oh.
What about anticholinergics? If I give someone an anticholinergic, what usually happens? They dilate the pupil all the way, right? If you dilate the pupil all the way, the light going in, not gonna work. And then usually you can't see well if the pupil is completely dilated.
Oh, how do you say? Mydriatic?
Mydriasis.
Mydriasis.
You have meiosis, where the pupil is small. Mydriasis, if the pupil is large. If it's meiosis, there are only two things that give you meiosis. Narcotics, such as cocaine will give you mydriasis. What will give you the small pupils?
Morphine.
Morphine. What class of drug is morphine?
That's not
Opioids. That's what I want you to say. I don't want you to say opioids. The two things that will give you a tiny, tiny pupil, opioids, and a PONS issue. An issue in the brainstem. You don't have to know that, but those are the things that give you meiosis. Or if you have Horner syndrome, okay, you'll get meiosis. Mydriasis, anticholinergics will give you mydriasis. Cholinergics will give you meiosis too, I'm sorry. Anticholinergics will give you mydriasis. Cocaine will give you mydriasis. So that's a sympathomimetics. Any sympathomimetics. Any anticholinergic is a sympathomimetic. Remember, if it blocks the cholinergic system, it enhances the sympathetic system. So your anticholinergics will block the cholinergic system and will enhance the sympathetic nervous system. So if it enhances the sympathetic nervous system, you're going to get the things that the sympathetic nervous system does, like mydriasis, increased heart rate, all that stuff. Okay, make sense, guys? Yes? Painful and Bilateral vision loss is very rare. Chemical exposure, somebody throws something in the eye, is about all that you will see. Macular degeneration, we talked about it. The central part of the retina is what's gone. Remember, they cannot read. What did you call it, David?
T-Rex.
T-Rex. They move their head from side to side. Now I get it, it's T-Rex for real. From side to side, okay? Because their peripheral vision is conserved, but their central vision is what's gone. Which eye condition takes away the peripheral vision? Glaucoma. Glaucoma is the opposite of macular degeneration. So in glaucoma, they usually lose their peripheral vision and the central vision is maintained. In macular degeneration, the central vision is gone and the peripheral vision is maintained. Okay? So the retinal central portion, known as the macula, is responsible for focus and vision, and it controls the ability to read, drive a car, recognize faces and colors, see objects and details. These are the things that are usually missing in macular degeneration. Okay? They cannot read. And this is what it looks like. Remember, this is the macular, and the fovea is right in the middle, and this is the macular here. Again, this is what it looks like. So in order to see that little girl, I'm gonna have to turn my head to the side here, and to the side here, because I can see on the sides, but I can't see straight. Okay?
Are they considered partially blind?
Yeah, I mean, they do end up with blindness, complete blindness.
I would give myself a
No, you won't.
That was a stream.
That's a lot of street. Oh, there's a lot of. Well, no worry. I won't have a philosophy bag, so
There you go.
that's your fetish. That's mine. I won't have a philosophy bag. All right. So, what is glaucoma? This is your canal of Schlemm. I like to say that word. I'm saying it wrong too, but okay.
Hello, Schlemm.
Like Schlemm's canal, the canal of Schlemm, where your aqueous humor, it actually goes through and actually circulates through the eye. This becomes clotted or blocked off when you have glaucoma. So you don't have that aqueous humor rotating or floating through the eye, okay, or moving or circulating through the eye, okay? And this is usually what you see, what happens in glaucoma. And they build up pressure. Okay? Some unilateral changes, ominous and should prompt immediate referral. Unilateral painless, retinal detachment, macular degeneration, retinal vein or artery occlusion. Unilateral painful, acute close-angle glaucoma. Optic neuritis. When do you see an optic neuritis? A lot of times.
Diabetes?
You can see it in diabetes. You see it a lot in myasthenia gravis. Patients with myasthenia gravis. They come in with optic neuritis. Gradual changes, macular degeneration, cataracts. If you are assessing your patient and you don't look, when you're looking for the red light reflex, you don't see the red light reflex, they have a refractory problem, they have cataracts. Patients who do not have a red light reflex have cataracts. So when you're assessing your patient with your ophthalmoscope, you're standing about what? 15 inches away from them, and you're locating the red light reflex. When you put the ophthalmoscope on your eye and you shine the light in their eye, you should see a red flash of light. That's your red light reflex. The people who won't have that are people with cataracts. Okay? So a person has a cataract, they will not have a red light reflex. Okay? Go ahead. I have no idea if that's the same thing or not.
Because every time I take pictures of it.
I know, I have the same thing. I think sometimes it's our cameras.
competency, we're not gonna have to really like look in there and be like, yo, you have cataracts.
Well, you're gonna say, if I don't see a red light reflex, yeah, I do. So if that person there and you're going up to them and you say, I see the red light reflex, and then 5 other people go behind you and say, I don't see a red light reflex. Looks really bad on your part.
Well, they might be wrong.
Like, do we replace it enough if we give someone cataracts and we're like, ah, I see it?
Yes,
We don't.
but no one's gonna have a cataract.
Okay.
Nah, no one's gonna have a cataract. And if someone has a cataract, I'll be merciful enough to tell you at the beginning that that person has a cataract, so that your nerves. I can see you guys, and I've seen students do it. They come in and they go, I see the red light reflex, and the camera shows the thing on the wall over there, and you're like, really, you see that? And the light is on the wall for the ophthalmoscope. And they go, I see the red light reflex. I
It's nerves.
don't. No, you don't. Okay? But yeah, we're trying, yeah. So,
Oh God.
if to help you guys, turn off the light when you're doing the ophthalmoscopic exam. Be like, for this exam, I'm gonna turn off the light. Actually, if you turn off the light, you can't see, so no, don't turn it off. Don't turn it off. But if you turn off the light, you can actually see it much better. If you don't turn off the light, it's harder. Yeah.
That's
It's
what I was
harder.
gonna ask you when we're doing this, because we have to turn off the light not only for the red light reflex, but also for constrictions when we checking for consensual
No,
reflex
you
and
don't.
stuff like
No,
that.
You don't. You can see it.
No.
You can see it with the light on. You don't see it as well, but you can see it. You can see it. All right. Test, visual acuity, we said Snellen chart. You can get them to read something, okay? Please, 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 at no point during your exam do anyone say, I tested Perla. What the heck are you testing when you test Perla? I take a point off immediately. I'm about to test Perla, or they haven't finished and they say, oh, Perla is intact. What Perla is intact? Perla means pupils are equal, round, and reactive to light and accommodation. So until you do the pupillary light reflex, okay, until you do accommodation, okay, until you do all that, you cannot tell me that pupils are equal, round, and reactive to light and accommodation. So if I don't see you take the light and say, look at the light, look at the light, look at the light, look at the light, follow it, you did not do accommodation. You can't tell me pupils are perlar. Okay? So don't use it as a word. It's not a word. It's an acronym. Right? It means pupils are equal, round, and reactive. When you look in one eye, you're going to shine the light in her eye, and you're going to look in that eye you're shining the light in to see if the pupils constrict, and you're going to look in the other eye for a consensual response. So you're going to see, I see a direct response in the left eye and a consensual response in the right. Okay? You must say that. You do not have to do this unless you didn't see it. You only have to do it once. And just look in both eyes. Okay? If my right eye constricts, my left eye should consensually constrict. Okay? Because the light reflex is going into the eye. Okay? So cranial nerve 2 gets the light reflex, cranial nerve 3 constricts the pupil. Okay? That's how they work together. Cranial nerve 2 senses the light, cranial nerve 3 constricts the pupil. Okay? Visual fields, your confrontation test. Your confrontation test I showed you guys last week. Make sure when you're doing your confrontation test, you have the patient, you say, look directly at my nose, don't move your eyes, don't move your head. When you're testing confrontation, you're checking peripheral vision, okay? So you're gonna say, look right at my nose, don't move your eyes, don't move your head. I know Deshawn said that she does it this way. Do you tell me when you see my fingers moving? Tell me when you see my fingers moving. Tell me when you see my fingers moving. Tell me when. You can do that too. You can say, tell me when you see my fingers, but you're slowly bringing them in. Tell me when you see my fingers, you're slowly bringing them in. Tell me when you see my fingers, slowly. Tell me when you see my fingers, slowly. You're not doing this, or this, or this.
Oh, no.
Because you're trying to kill somebody or blind somebody and poke somebody's eye out. Or you're going to say, how many fingers do you see? 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 Okay? If you have your finger all the way out here and you can't see it, your patient can't see it. Because when you're checking peripheral vision, you're checking theirs against yours. So you're assuming your peripheral vision is intact. Okay? All right. Extraocular movements. You're checking cranial nerve 3, 4, and 6. Okay? Always remember cranial nerve 4 to the floor. Okay? Cranial nerve 6, lateral. Cranial nerve 3, everything else. So, up and out, 3. Up and down, 3. Medial, 3. Up and in, 3. Lateral, 6. 4 to the floor. Okay? People who have cranial nerve 4 deficits cannot walk downstairs. Because if you never know that you're walking downstairs, you have to look down. You have to be able to look down and in. If you can't look down and in, because usually what happens with a cranial nerve defect, and you'll get this in your neuro lecture, is if I have a cranial nerve 6 palsy, what's going to happen is that the medial rectus muscle is going to actually pull my eye in. So the muscle, the opposite muscle, is actually going to have going to take over. So if my lateral rectus muscle that pulls my eye out is not working, the medial muscle is going to pull it in. So what's going to happen is my eye is going to rotate inward. If I have a cranial nerve 3 palsy, my eye is going to rotate outward. So the lateral rectus muscle will take over. Okay? So if I have a cranial nerve 4 palsy, I can't walk downstairs because cranial nerve 3 is going to take over, and my eye is going to rotate up and in or up and out. Okay? So then my eyes are going to be like this. So I definitely can't walk downstairs because I can't see. Because my eyes are going to rotate back.
So in that case, when you do the 4, the person is not able to like do this.
If I do a 4 and you have a cranial nerve 4 palsy, your eyes are going to roll up, and I tell you to look down, you can't go down. 4 is down and in. Okay? 3, down and out. 3, up and out. 3, up and in. Okay? 3, medial. 6, lateral. 4, down and in. Okay? And you have to say what number you're looking at when you're doing it. You have to say cranial nerve 3, cranial nerve 3, cranial nerve 6, cranial nerve 4, cranial nerve 3, cranial nerve 3. Okay? 6, 4, everything else, 3. Okay? Cardinal fields of gaze, we talked about, and we'll talk about it more in neuro. Confrontation test, this is your checking your peripheral vision. Your confrontation test tests cranial nerves, which one? 2. Peripheral vision is cranial nerve 2. So they're asking you about testing through confrontation, you're checking cranial nerve 2. That is a test question. You always ask it. Somebody always gets it wrong. Cranial nerve 2, confrontation. Okay. So your quadrants, your visual fields. This is when we say you have a quadrant that is lost. We're talking about your right upper quadrant, your right lower quadrant, your left lower quadrant, and your left lower quadrant. Upper and left lower. Okay. We talked about this. Visual fields. Okay. When you're looking at visual fields, remember you have a right visual field and you have a left visual field. Your right visual field is everything going to the right. Your left visual field, well, that's my right. You're right. Okay? So your right visual field is basically, if I say this person has a left henominous hemianopsia, that means their left visual field. And it's in both eyes. Okay, guys? It is in both eyes. So think of your eyes and separate it in two, by down the middle. Okay? Then you have right visual field, left visual field. So this inner part of my eye here is my left, and the outer part of my eye here is my left. The inner part of my eye here is my right, and the outer part of my eye here is my right. So if I have a left henominous hemianopsia, that means, or if Kim has a left henominous hemianopsia, when I test her, I'm going to say, look at my nose, okay? And if I go here, she'll be able to see it, because that's on the right. But if I go here, she will not be able to see it, okay? And when you're doing it, when you notice someone has a deficit, you're going to ask them to cover the eye. When you're doing a gross visual field test, they don't need to cover the eye, because usually they're intact. But if you detect something, they're not seeing something, then you're going to have them isolate the eye. So you're going to have them cover the eye, and then they're going to, so, do you see my fingers? If they see it out here, but don't see it here, they have a left visual field deficit. If they see it, don't see it out here, but they see it in here, they have a right visual field deficit. And then you expect the same thing on the opposite eye. Does that make sense, guys? All right. So, visual field defects, it depends. Blindness in the right eye usually means that there's something going on, probably intrinsic to the eye. Okay? One, a unilateral blindness. Okay? Left henominous hemianopsia, it usually means it's coming from the occipital lobe. Okay? It usually means that they have a stroke in the occipital lobe, and it's coming from that right side of the brain. So the right occipital lobe is infarcted, and it's giving you a left henominous hemianopsia. Because if you remember, the right side of the brain, the right occipital lobe feeds the left visual field, and the left occipital lobe feeds the right visual field. Okay? Left henominous hemianopsia in the superior quadrant, or is a quadranopia, is usually due to a pituitary macroadenoma. Okay? So go back to your endocrine lecture in patho. When you did your endocrine lecture in patho, you talked about pituitary macroadenomas, correct? You talked about tumors of the pituitary gland that can actually secrete hormones. So if someone come in and they have a pituitary tumor, the pituitary gland sits, it's the sphenoid wing, and it actually has a sella turcica, which sits at the bottom here, and it has like a little opening, and that's where your pituitary gland sits. Now, above the pituitary gland is the optic chiasm, okay? And the optic chiasm, if I have a pituitary macroadenoma, it's gonna grow and grow and grow, and it's gonna actually compress the optic chiasm. If it compresses the optic chiasm, usually what you have is bitemporal hemianopsia, and sometimes you can have the quadranopias, depending on how much it compresses. So if they have bitemporal, meaning my left visual field on the left, on the right eye, the right is gone, and the left eye, the left is gone. Usually it's bitemporal, both sides out both sides are gone. That usually means it's coming from a pituitary macroadenoma, because usually what happens is the pituitary gland is growing, or a mass is growing there, and it's actually compressing the optic chiasm, which actually takes out the bitemporal visual fields. Does that make sense, guys? Does that confuse anybody? Clara? Come on, Clara. If I have a tumor that grows here, this is your sella turcica, where your pituitary gland sits. Above it is the optic chiasm. Normally, nothing compresses. But if I have a 2-minute grows, it's gonna compress it and it's gonna go up. When it compresses the optic chiasm, usually what happens is bitemporal. So both sides gone, okay? If it's a homogeneous hemianopsia, one visual field gone, okay, the same visual field gone, it's usually the occipital lobe. If it's a bitemporal hemianopsia, it's usually pituitary adenoma. Okay? So in your question, if it says bitemporal hemianopsia, think pituitary. If they're telling you a homogeneous hemianopsia, is how you spell it, you are thinking stroke in the occipital lobe. Okay. Fields of gaze, we talked about this. So the lateral rectus is 6, medial rectus is 3, inferior oblique is 3, superior rectus is 3. We have inferior rectus is 3, and superior oblique is 4. Okay? So if you have, again, you have a cranial nerve palsy, let's say you have a cranial nerve 3 palsy, your lateral rectus is going to take over. You have a cranial nerve 4 palsy, your superior rectus or inferior rectus is going to take over. If you have a cranial nerve 6 palsy, your medial rectus is going to take over. So if you have a picture and the eye is rolled in, then you know it's a cranial nerve what palsy? 6. Because that means this lateral rectus muscle is not working. If you have a patient and the eye is rolled up, what palsy is that? 4. That means your superior oblique is not working. You can't pull it down. If you have a patient and the eyes rotate laterally, what cranial nerve is that? 3. That means the medial rectus cannot pull it medially. Does that make sense?
Yeah.
When? Okay, let's think about it again. That's okay. That's okay. Not the easiest to understand, so just tell me you don't, and I get you. Okay, so usually if you have a palsy, okay, what usually happens is that the other muscle is stronger. So if I have a cranial nerve 3 palsy, that means the medial rectus muscle that pulls the eye in is not working. So that means if this muscle that pulls the eye this way is not working, then this muscle that pulls the eye that way is going to take over. Okay? So if my eye is rotated outward, I know this muscle is not working. Does that make sense?
Yes.
If my eye is rotating upward, this muscle is not working. Make sense?
Yes.
And if my eye is going that way, then this muscle is not working. If it's going this way, that muscle is not working. Does that make sense?
Yes.
Anybody else have an issue? Okay. Got it? Neuro is not the easiest to understand, so if you stop me, not a problem. Please do not leave the classroom if you don't understand it. Just ask it. All right, this is what we just talked about. It's just another picture that looks a lot, that gives you a little bit more explanation. Anybody have any questions on that, or we good? We're good. All right. So we have our cardinal fields of gaze, okay? And we have 6 cardinal fields of gaze, okay? We can take the eye to the star, or we can take it through the letter H. It depends on what you like. You can go H, or you can go star. Okay, star is easy. H is easy too. I can make a perfect H. Okay, it's up to you. Whatever works best for you. Accommodation, okay? You cannot see accommodation. You can only perceive that the eyes accommodate when the patients, you bring the object close, the pupils constrict, and the eyes converge. So, I bring it close, pupils constrict, eyes converge, then I can say, of course, after I've shown the light in the pupil, and the pupil constrict, I can say pupils are equal, round, and reactive to light and accommodation. Okay? And I'm not gonna say pupils are perla. I'm gonna say pupils are equal, round, and reactive to light and accommodation. Okay? I tell you guys that because when you say it, my neurosurgeons, they think you're idiots. And they go, these people don't know crap. They do, trust me. I have one neurosurgeon, he'd be like, he says to me one day, what do you teach those people? And I'm like, not all of them went to Barry, come on. He tells me, like, in nurse practitioners, and they don't know, he's like, what do you teach those people? I'm like, and I tell him, what do you teach those ER physicians in medical school? He's like, because he talks about them so bad, he's like, those people, those are the ones that just couldn't get anywhere else, so they just settle for that. They think very low of them. They're like, they couldn't do anything else, so they just settled for that. Okay? So, when I tell you guys, I want you to say the right things, because when you call and tell them the patient has ptosis, they're like, I don't even want to talk to you anymore. I'm dead serious. They don't even want to talk to you anymore. Because you don't know what you're saying. Okay? So it's not perla. Pupils are equal, round, and reactive to light and accommodation. Okay? And I'm going to be grading somebody in this class, and they're going to say some crap like perla, and I'm going to be like, oh, God have mercy. All right. Nystagmus. Okay? We can have horizontal nystagmus or vertical nystagmus. It depends on what's going on with the patient. Okay? You see it a lot in patients with things like benign positional vertigo. You see a lot of nystagmus in those patients. Okay? You move their head, pull them up, and then they have oscillating nystagmus. Okay? Eyes deviation. Esotropia versus exotropia. Okay? Esotropia, moving the eye in. Exotropia, the eye goes out. Okay? And usually these are patients, they call them cross-eyed. Okay? They say the patients are cross-eyed. And usually what happens is that the patient's eye goes out and rests that way on one side, the exotropia. Or esotropia, where it comes in and rests in. And they say people are cross-eyed. Are you cross-eyed, Dave? Who do you know somebody who is? Nope. Liar. Liar. Diplopia. One thing I want you to remember, if you never remember anything I ever teach you, if diplopia disappears when they close one eye, it is coming from the brain. If you never remember anything else I teach you about diplopia, remember that.
When they close one eye?
If they close one eye and they tell you, oh, it's no longer two people, it's coming from the brain. If they close one eye and it doesn't go away, it's coming from the eye. Okay? You can have horizontal diplopia versus vertical diplopia, and it depends on which cranial nerves are involved. Horizontal, 3 and 6. Vertical, 3 and 4. Okay? So if I have a horizontal diplopia, I'm thinking either cranial nerve 3 and 6 are having an issue. If I'm having a vertical diplopia, I'm thinking either cranial nerve 4 or 3 is having an issue. Okay? Does that make sense? Unilateral usually means it's one eye, again, is coming from the eye. If I close one eye and the diplopia goes away, it's coming from the brain. Okay. Have it there. Centrally induced means it's coming from the brain. Nystagmus, rhythmic oscillation of the eyes. Okay? It's never a normal thing to see nystagmus. Okay? There's always some pathology going on. Huh?
Or drunk.
Or they're drunk, yeah. That just means that their cerebellum is off key. Seriously hockey. Okay. Or they have an inner ear issue. Okay. I don't know why this is here, but it's up above again. I don't know why I have this there again. We talked about this already.
Mhm.
We talked about that. Uveitis. Uveitis is someone comes in and they're telling you that they have this really bad red eye with some vision changes. It could be uveitis. If they have Crohn's disease, it's probably uveitis. Or if they have any type of inflammatory disease, it's probably uveitis. Keratitis, it's an infection of the outer part of the eye that can actually lead to blindness. I had a dose of keratitis. Now, I got keratitis because I thought I was cute. Like in my 20s, I used to wear these green contact lenses. And man, I was cute. My green contact lenses. So of course, I met this guy. And you know, you want to sleep in your contact lenses and wake up in them. I mean, you don't want to take out your contact lenses. We went out, my eyes were green, now we come home, my eyes are dark again. Yeah, so let me sleep in my contact lenses. So, did that a couple times, Not cleaning my contact lenses, right? But I was cute. I was real cute. And I'm like, slowly but surely, I'm like, wait, I can't see. Oh my, it's getting really bad. And then I think I was at work. Somebody was like in the nurse's station calling me. I had a hard time making them out. I was like, this is kind of weird. So I went to the eye doctor. And he was flipping out.
What were you thinking?
The guy was flipping out because he was like, oh my God. I had the worst case of keratitis. I was actually seeing the big letters. I must have had like 2060 or 2100, I don't know. It was so bad. I could not wear contact lenses legit for like almost 9 months. It was so bad. I was on eye drops. What do you call it? Ocular antibiotics and oral antibiotics. Yeah, no. And clean them. Okay? Don't be all cute. That's what I was. Now I just dispose of my contact lenses every time I wear them. But okay. Yes. And we keep them for too long sometimes. And that was my thing too. I was keeping them too long. So, you're young and dumb. I learned. Okay. But keratitis is an infection of the outer part of the eye. It can actually lead to blindness. And contact lens users are high risk. Okay. Orbital cellulitis, we know what it looks like. Okay. Eyes, cornea, clear dome, surface of the eye become inflamed, marked by moderate intense pain, usually involves any of the following symptoms: pain, impaired eyesight, photophobia. I had light sensitivity, impaired eyesight, and I had red eye and a gritty sensation. I had pain, but it was horrible pain. Huh?
And you kept wearing the contacts?
Oh yeah. I was cute. That was the only thing that made sense. I was in my 20s.
I'm sorry, your eyes are hurting.
That would be pretty awesome.
I know, right? Made no sense, but I did it. Look. I didn't say it was smart. I just said it was cute. I didn't say it was smart. It wasn't one of my smartest days, okay? They can actually have fungal keratitis and bacterial keratitis. Okay? It looks horrible. I wasn't that far yet. Okay? Your patient has Crohn's disease, complaint of eye pain and photophobia. This is likely what? Uveitis. Oh, you guys are so good. Pay attention. Orbital cellulitis. Yeah, eye issues are not fun.
They're not cute.
They're not cute. Okay. Peritoneum, I can never pronounce this word. Is actually that fold that grows over your eye. Peritoneum. My mom had it, and she's had to have cut it off a couple times, but it grows right back. Corneal Abrasion. That green light on your ophthalmoscope, that's what we use that for. We put the dye and we use that to look for corneal abrasions. Hyperopia is just basically blood. Hypion is pus. Pion is pus, emia is blood. Okay? The ophthalmoscope, we talked about it. Diopter to zero. Red if it's myopia. Green if it's hyperopia, meaning presbyopia or hyperopia. Okay? So if you're nearsighted, you're gonna go towards the red. If you're farsighted, you're gonna go towards the green. Okay? Patients focus your eyes over the shoulder, red light reflex at 15 inches, and then move closely. Again, your ophthalmoscopic exam is actually to check cranial nerve 2. Red light reflex, optic disc, retinal vessels is what we're really looking for. Okay, guys, do you need a small break?
Yeah, I think it's
Yes, go pee.